of uncomplicated type B dissection, which is, I guess, one of the more controversial aspects of thoracic endovascular management at the moment. So in terms of disclosures, I'm PI on the Virtue study, which I'll speak about later. So this is the clinical dilemma, I think. This is a patient who came into our unit about 2 weeks ago, 35-year-old male with no connective tissue disease, long-standing hypertension, came in with 6 hours of back pain. His BP was controlled very quickly. His pain settled very quickly. He was ready for discharge on day 5. And on his CTA, he had an uncomplicated type B, no malperfusion, had a big proximal tear. And really the question is, how do you manage this guy at the moment? And these are your options, really. You can do a hyperacute TEVAR in the first couple of weeks. You can treat him with best medical therapy and put him on a surveillance program, or you can do somewhere in between those two options of best medical therapy and early interventions with TEVAR. And I think this middle option is probably the best form of therapy for most patients with uncomplicated type B dissection at the moment. Well, why do I say that, given that all the guidelines suggest that you should be undertaking a primary conservative approach with best medical therapy and surveillance for these sort of patients? Well, time changes and opinions and evidence change with time, and what I want to do today in the next few minutes is just go through the recent evidence that I think suggests we should be adopting a slightly more aggressive approach with uncomplicated type B dissections than we have done previously. So what do we know about the management of uncomplicated type B aortic dissection? Well, we know that in the medical phase of management, in the hyperacute phase, treating patients with truly uncomplicated dissections with anti-impulse therapy is pretty safe. This is a paper from Hazim Safi's group demonstrating that in patients with truly uncomplicated type B dissection, the mortality with good medical management is just over 1%. We also know that if you leave patients with uncomplicated acute type B dissections to become chronic, they will have a significant mortality over the next 5 to 10 years. So this is a reasonably well-quoted paper by Winnerquist from Sweden that demonstrates a 25% rate of aortic-related events within 5 years and a 15% death rate at 5 years due to dissection-related causes. And the study really that changed, I think, most people's approach to uncomplicated type B is the INSTEAD trial. This is Christoph Nienauber's trial, 140 patients randomized to best medical therapy or thoracic endografting using the TALENT graft, which is by no means a good graft for dissections. What the study found was that there was an excess early mortality associated with the implantation of a thoracic endograft, but there was favourable aortic remodelling, and this translated to a late survival advantage in the endograft group. And this is the graph that's often quoted. The red line is the thoracic endografts, the blue line is the best medical therapy, and what you see essentially is that after 12 months, all the deaths were in the best medical therapy group. Thoracic endografting appeared to convey a protection from aortic-related death. And if you look at the late deaths in this table, it's quite stark really. No deaths in the TEVAR group and 12 deaths in the best medical therapy group. And the worry here, I think, is that what we prescribe for our patients at the moment, which is best medical therapy and surveillance, is quite clearly not protecting patients from aortic-related death. So what are the implications of the INSTEAD trial? Well, as I said, the implication is that surveillance doesn't prevent aortic death. TEVAR appears to prevent late aortic-related death, and given that endografts have improved, you'd like to think the early TEVAR mortality should improve, but it's really very small numbers, and that's why the IRAD data that have recently been published are really quite compelling. Over 1,100 patients, and although it's non-randomized and it's a registry, these curves overlap with what you see in the INSTEAD trial, with the endovascular patients having a survival advantage. So where does that leave us? Well, I think we can say that the late aortic complications of uncomplicated type B do justify early intervention, even though there is some attendant mortality. And I think the two big unanswered questions are, should all patients with uncomplicated type B be treated, or can you target the intervention to specific groups? And if you are going to intervene, when should you do that? Well, targeting, I think, will be difficult, because if you look at the predictors for an adverse outcome after uncomplicated type B aortic dissection, they're this list, and actually this pretty much covers most patients. So targeting is probably not for us at the moment. What about timing? Well, if you're going to treat uncomplicated type B, you need to strike a balance between the clinical outcomes of the thoracic endografting and the extent of aortic remodelling that you will achieve. And I think ideally you want to do your thoracic endograft as late as possible after the index event, so your incidence of retrograde type A dissection will drop off, but you don't want to do it so late that you won't get complete aortic remodelling. And at the present time, we don't have a great deal of information about remodelling in the subacute patients, and that's where the Virtue trial comes in. So this was a Medtronic-sponsored trial of 100 patients with dissection in Europe, and the relevance of this trial is that it broke up the patient cohorts into those with acute dissections, so less than 2 weeks after the index event, chronic dissections greater than 3 months, and this subacute group somewhere in the middle. And what you notice here is the outcomes for the subacute group are very good. But the main relevance is in the remodelling. Now, this is a difficult slide, and what essentially it shows is the change in both false lumen area and true lumen area 3 years after a thoracic endograft for a dissection. So the acute patients are in blue, the chronic patients in green, and the subacute patients in red. And essentially, what we take out of this is, if you look at false lumen area, you get a reduction in both the acute and subacute group after TEVAR. In true lumen area, you get expansion in the acute and the subacute group, and the chronic group don't remodel at all. And there is no difference in the extent of remodelling between the acute and subacute groups. If you look at false lumen thrombosis, you see exactly the same thing. The graph on your right-hand side is false lumen thrombosis at the diaphragm, and you see essentially the same degree of remodelling in the acute and subacute groups. So where does that leave us? Well, I think it leaves us here. If you don't offer TEVAR to patients with uncomplicated type B, you will lose your window where you can effectively remodel the aorta. The dissection will become chronic, it becomes more difficult to treat, and I think most importantly, you will embark on a surveillance regime that does not appear to prevent aortic-related mortality. On the other hand, if you do offer TEVAR, you have to accept that there will be a small early front-loaded mortality, but that's pretty much the same as any aortic operation. You will, however, effectively prevent aortic-related death. You will completely remodel the aorta, and this is just what we do, prophylactic surgery to prevent aortic-related death. Thank you.